Good afternoon, everyone. My name is Margarina, and I work in WHO Regional Office for Europe, where I lead the work on evidence to policy. Very honored to welcome you here and co-chair this very important panel. At least, I don't know how about you, but at least for me, the red thread of the previous discussions and plenaries has really been the question on how we as a community can do better in applying the power of science and research in addressing the challenges that the current world is facing, improving people's health and their lives, which is also one of the mandate, the real mandate of WHO where I'm working. This session is looking into the different avenues on how we can be better at translating evidence into impactful practice and policies. We are looking into different networks of policy and research, different models, and how practical solutions can help us. I'm really privileged to co-chair this plenary. Colleague Lawrence, please introduce yourself and let's get it on.
Thanks, Margie. Good afternoon, everybody. My name is Lawrence Mbwagbo. I am a research methodologist and associate professor at McMaster University in Canada. I am also the co-director of Cochrane, Cameroon. And I do have the immense pleasure of presenting our first speaker, Professor David R. Williams, who is the Norman Professor of Public Health and African American Studies at Harvard University. His prior appointments were at Yale University and the University of Michigan. He has over 500 scientific papers and have examined how race, socioeconomic status, racism, stress, health behaviors, and religious involvement affect health. He was ranked as the most cited Black scholar in the social sciences and as one of the world's most influential scientific minds. He was elected to the National Academy of Medicine, the American Academy of Arts and Sciences, the National Academy of Sciences, and the Royal College of Psychiatry. Ladies and gentlemen, please give a hand for Professor David Williams.
It's truly an honor to be here with you today and to talk about an important topic, what we can do to reduce inequities in health. And my plea is for it that there's an urgent need to translate the science that we have into innovative solutions. The aspect of inequities I'll talk about with a heavy emphasis on racial, ethnic inequities in health in the United States and around the world. I'm going to illustrate that with infant mortality data for the US. And you could see that Blacks, Native Hawaiians, and other Pacific Islanders, American Indians, and Alaska Natives have markedly higher levels of infant mortality than the white population and other populations. The US is not unique. If you look at data for the UK, you can see that Pakistani and Blacks from Africa, Bangladeshi, Blacks from the Caribbean, and Indian, that's Indian immigrants, also have markedly elevated rates of infant mortality. If you look at South Africa, you can see that Blacks have the highest rates of infant mortality, followed by colors, Asians, and Indians, and then whites. So if you look at Latin America, you can see the Afro-descended population in virtually every country in Latin America where there's data. Costa Rica, Panama, Uruguay, Venezuela, Brazil, Ecuador, Colombia have markedly elevated rates of infant mortality. Still, looking at Latin America, the indigenous population in Latin America has elevated rates of infant mortality in every country for which there is data. And these large gaps in health that exist by race are quite persistent over time. One example of that is looking at life expectancy by race for Blacks and whites in the United States from 1950 to 2020. And you could see there was an 8-year gap. The average white person lived 8 years longer than the average Black person. The good news in the data is through 2010, life expectancy increased for blacks, increased for whites, and the gap was narrowed to a 4-year gap in 2010. And then the COVID pandemic hit in 2019 with marked declines in life expectancy for all groups in America, but larger declines for blacks and Hispanics than for other groups. And so you could see life expectancy in the US for both whites and blacks has declined from the 2010 level, and the gap is 6 years in 2020 compared to the 4-year gap in 2010. And this pattern, I've just focused on infant mortality, life expectancy. This exists for a broad range of outcomes. We don't have time to go through all of them. And race ethnicity is strongly related to socioeconomic status. And when my career started, most researchers thought that racial ethnic differences in health were simply a function of racial ethnic differences in income and education and occupational status and wealth. We now know that life is more complicated than that, but let me illustrate the gaps by socioeconomic status. This is median household income in the United States by race for 2018, national data from the US Census Bureau. And I'm standardizing on the household income of whites as $1. For every dollar of household income white households receive in the United States, Asian households receive $1.23. Several caveats to keep in mind to make sense of the Asian data. One, Asians have the highest level of college completion in the United States, almost twice the rate of college completion compared to whites. Asian households also have more persons contributing to household income than any other racial group, and almost 2/3 of Asians in the United States are immigrants. But let's look at the historically disadvantaged groups. For every dollar of household income white households receive, Hispanic or Latino households receive 73 cents, and Black and Native American households receive 59 cents. What is stunning about the 59 cents figure for blacks in 2018 is that is identical to the black-white gap in income in 1978. 1978 was a peak year of the narrowing of the black-white gap in income as a result of the civil rights policies of the 60s and 70s and the war on poverty of the 60s and 70s. And in 2018, it's still 59 cents. Has it been stuck at 59 cents? No. It got worse throughout the decade of the 1980s, and in the mid-1990s got back to 59 cents. It's a penny up and down since then. The important take-home point is we have made much less progress on reducing these gaps than most people think. Here is another example of the relationship between race and income. This is data from South Africa for 2014-2017 and 2014-2015. For every rand of household income white households receive, Indians receive 60 cents, coloreds 40 cents, blacks 20 cents. So again, large gaps by income. However, the large gaps in income and education markedly understate the racial gap in socioeconomic status. And what do I mean by that? Well, income and education captures the flow of resources, or income, the flow of resources into the household. It tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth, your savings, your investments, your home equity, and so forth. And for every dollar of wealth that white households have in the United States, blacks have 10 cents and Hispanics have 12 cents. And in the UK, for every pound of wealth that the white British have, Indians have 95 pence, Pakistani 50, blacks from the Caribbean 20, blacks from Africa and Bangladeshi 10. So I'm showing you patterns consistent across societies of these large gaps. But strikingly, my work and others have shown that race still matters profoundly after we've taken income and education into account. And I will share with you one study we published years ago using national data for the United States, looking at life expectancy at age 25. At age 25, the average white person lived 5 years longer than the average black person. So a 5-year racial gap. The gap by education and income, I'll only show you in education data in the interest of time, is larger than the racial gap. So there's a 6.4-year gap between the best off whites with education and the worst off whites in education, and a 5.3-year gap, again, between blacks with a college degree or more education and blacks who have not completed high school. So you could pause and say, well, we shouldn't even bother with race, since the socioeconomic gaps are larger. And I would say not so fast. Why? Because race matters at every level of income and education. Here is at education, whites who have dropped out from high school live 3.1 years longer than blacks who have dropped out from high school, And the best of blacks, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who have graduated from high school. So what do these data tell us? They tell us there's something about race or socioeconomic status that matters for your health, income and education, regardless of your race. But there's something else about race that matters profoundly for your health, even after you've taken income and education into account. And there's a whole body of work documenting the multiple ways in which racism matters for health. So what can we do about this? What are the needed interventions? And I want to share with you high-quality scientific interventions that shows there are things we can do that we as a global society is not doing. So this is a report published in 2003 in the United States that documented there is unequal treatment within the healthcare system based on an individual's race. To illustrate the problem still persists, there was a 2003 report. I'm sharing with you a 2023 paper. It was a study of 318,000 elderly patients with the same insurance across the United States. All of them had the same diagnosis, advanced cancer in their last weeks of life. And the question is, do they get opioid medication for their pain? Well, black and Hispanic patients were less likely than white patients to get opioid medications for pain. And when they got medication for pain, they got smaller doses. And black patients were more likely to undergo urine drug screening. They're dying of cancer, last weeks of life, undergoing urine drug screening to see if they're abusing opioids. And black men experience the greatest inequality in both access and urine drug testing. So just an example of how race matters profoundly for the care that individuals receive. One of the challenges we know is the need to reduce implicit bias in providers. However, this is a review of 900 studies of anti-bias training and 400 studies of implicit bias training. The trainings raise awareness levels, but they do not change implicit bias in any major way. Is there anything we can do? Yes. I'd like to talk about the Devine solution. Professor Patricia Devine at the University of Wisconsin has shown that you can develop a program that is effective in reducing implicit bias, and that the reductions are evident even 3 months later. It doesn't sound like a long period of time, but longer than has been done in most studies. What's different about what she does? It's a 12-week curriculum. There are homework exercises. It's not a 2-hour workshop. The 2-hour workshop raises awareness levels, but doesn't change deeply ingrained habits, patterns of behavior. And so this is an example of a study that was published, shows 2012, that there are strategies that can be effective in doing it. Another strategy where we have good data is that if we diversify the workforce, it can enable us to meet the needs of all patients. So here is a randomized controlled trial done in Northern California. Took 1,300 black men, gave them a coupon to go to a Saturday morning clinic. When they got to the health clinic, they were randomized to see a doctor of their own race or a doctor of a different race. Those black men who saw a black doctor were more likely to talk about other health problems, more likely to do the screening for diabetes, more likely to get a flu vaccine, more likely to do the screening for cholesterol, so much greater engagement with the healthcare system when there was that racial concordance. Another effective intervention is if we can provide care that addresses the social context of individuals instead of only focusing on the organ system that is sick. And I'm sharing with you a randomized control trial done in 1978. So we've had this data, that's my point. We have high quality scientific data for decades. Lensheim took 244 low-income hypertensive patients, 80% of them black, randomly assigned them to 3 conditions. 1, routine care, go to your doctor, get the medication, go home. Second group, in addition to routine care, went to a core meeting once a week for 12 weeks, by a professional health educator, taught them about hypertension. The third group, routine care, they took lay people from the local community, give them 1 month of training about the basics of hypertension, but also about the resources that existed in the community to help people with problems they face. And these lay health workers made home visits, and they talked about blood pressure, but they also referred individuals to the resources that exist. They didn't create new resources, referred them to resources. 7 months later, patients who had the lay intervention knew twice as much about blood pressure than patients in the other two groups. They were more compliant in taking their blood pressure medication, and taking medication was twice as successful in controlling blood pressure in this group, and they were much more likely to have their blood pressure controlled. So we know what's different here. Their blood pressure was understood and addressed within the context of their lives. And we know that this works. Why aren't we doing more of it? Another effective intervention, investing in early childhood to improve adult and not only child and adolescent outcomes, but even adult outcomes. Here's another randomized control trial done in North Carolina in the 70s. They took children at birth, poor children, randomized them to an early childhood program where they got a safe, nurturing environment, good nutrition, good pediatric care. The program was only birth through 5. The intervention, birth through 5. By age 21, better mental health, less drug use, more active lifestyle, better educational success, better vocational success. By the mid-30s, markedly lower levels of cardiometabolic risk. What else do we need? Another example of effective interventions, improving neighborhood and housing conditions. Rash Chetty, an economist at Harvard University, shows that even when you compare black and white children who grew up in the same household, the households with the same level of income, you look at the kids in the next generation, in 99% of households, black boys have lower earnings than white boys, even when their parents had the same level of income. Why? They're lazy? No. They lived in neighborhoods that differ in access to opportunity. If we improve neighborhood conditions, would it make a difference? Yes. The Move Into Opportunity program is an example of a low-income public housing program where they randomize these residents to move to better housing. The only intervention, no health intervention, just change the housing. What they found, 3 years later, better mental health for the parents and sons. 10 to 15 years later, lower levels of obesity, severe obesity, and diabetes risk. What's holding us back? Why aren't we acting on the evidence that we have? I think we have 3 challenges. We need to raise awareness levels that these solutions exist and we can do them. Secondly, we need to build empathy so that we feel the pain that other groups suffer. And third, and most importantly, we need to develop the political will to act on the evidence that we have. I leave you with the words of Martin Luther King. True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. We in public health need to address those edifices that are producing inequities on a large scale. Thank you.